The lecture today is going to focus on the treatment of offenders with mental disorders. While all of the topics that we discuss in this course I feel are very important topics and things that we need to consider, this is one that is particularly near and dear to my heart because as a psychologist, we work with people with mental disorders. And I've often heard it said that you can see the value of a culture by looking at how it treats its most vulnerable individuals. And in our society, some of the most vulnerable individuals that we have are those with persistent mental illness. And you'll see in this lecture that we have not yet done a very good job of treating these people with dignity and humanity, and we have significant issues and problems that we need to discuss. And you'll be viewing that as well in the video that you've seen for the discussion. So just to give you a bit of a history, just to kind of see where we are today. Back in 1959, there were nearly 559,000 hospital beds for those with mental illness in the U.S. I mean, that might have been excessive. I mean, sometimes, back in the day, we were keeping people locked up for reasons that they did not need to be locked up for, like such as kind of mild to moderate depression, for example, or anxiety disorders where people live much more successfully when they are living in the community. But given this, there was a move to then deinstitutionalize, meaning to get people out of the institutions because people were living there for years at a time and then were having troubles reintegrating back into society because they became used to these institutional environments. A lot of that then became drives to cut budgets because these hospital beds and psychiatric facilities are very expensive. So by the late 90s, we only had 70,000 hospital beds. And right now in the U.S., there are only 37,000 hospital beds. So you can see we went from 560,000 hospital beds to 37,000 in about five and a half decades. So that's kind of scary because there are not fewer people with mental illness. There are just fewer resources to treat those individuals. So what we found is that people who were being released back into the community just were not adjusting adequately. And so, we need to provide support services. And so what was happening was that those people who continued to be suffering from mental illness were coming in contact with the criminal justice system and were getting incarcerated. So as a consequence, as the number of hospital beds decreased, the number of individuals in the criminal justice system with a mental illness significantly increased. There are currently, in 2014, the latest data I could find, 383,000 mentally ill adults in prisons and jails. Rikers Island, for example, is the largest psychiatric facility in the U.S. And when I say psychiatric facility, it means it houses the most people with persistent mental illness, and it's a jail, as opposed to any kind of psychiatric facility. So we are seeing that our mentally ill individuals are ending up in the criminal justice system. That is 10 times the number of people who are currently in psychiatric hospitals. We see that a lot of people with persistent mental illness who end up in the criminal justice system are also self-medicating with drugs or alcohol, and they have what's called a dual diagnosis. So they have a substance abuse or use disorder as well as a persistent mental illness. And as you can imagine, this has significantly strained the correctional justice system because it's not set up to deal with individuals with persistent mental illness. And so we are not equipped with adequate mental health services to deal with these large numbers of individuals with mental illness. So here are some data. So you can see there are currently in state prisons 56% of the individual have any kind of mental health problem, 45% in federal prison, and 64% in local jails. Those with a recent history, meaning that they are currently suffering from some ill effects of mental illness. You have about a quarter in state prison, 14% in federal prison, and 21% in local jails, and those are experiencing symptoms ranging about the 50 to 60 percentile. We also see that those in prison with a history of mental health problems are more likely to have past violent offenses, substance abuse problems, drug use, are more likely to be homeless, have past physical or sexual abuse, have parents who are abusing substances, charged with violating facility rules, and being injured in a fight since admission. And some of those are almost double what the individuals without a mental illness are facing. So you can see that not only are these people coming with different types of histories, meaning different criminogenic needs, but also once they're in the facilities, you're seeing more violation of rules and aggressive fights, which could be due to the poor maintenance, regulation of their mental illness. So we also see people with mental health problems are more likely to be homeless, are less likely to be employed, more likely to be physically and sexually abused, more likely to be growing up in public assistance. And the reason for that is because oftentimes persistent mental illness runs in families, so their parents probably were kind of taken away at some point, and therefore they would be living in public assistance if they didn't have relatives or another parent that could take care of them. Again, their parents were more likely to use substances, drugs, and alcohol, and their parents were also more likely to be incarcerated than those without mental problems. And so since admission, about 61% of those in state prison and 41% of those with mental illness received some sort of treatment in terms of counseling, medication, or other mental health services specifically for their mental illness. So there are some mental health laws. Here in New York State, we have CPL 730, which is felony defendants found to be incompetent to stand trial. So that means that they are currently too psychotic, or they cannot understand and they cannot adequately participate in their trial. So they would go to a facility like Kirby on Ward's Island, where the goal would be to restore them to competence so they could participate in their trial. We then have defendants found not responsible for criminal conduct due to mental disease or defect. That's the kind of the typical, what we used to think of as NGRI, or not guilty by reason of insanity. That's CPL 33020. This is very hard to get. Very few cases are successful, but this means that during the commission of your crime, you were so mentally ill that you were not able to see right from wrong. Even if this is largely the case, or if your mental health symptoms influenced your ability to make adequate decisions, it's very hard to prove this, and the defense is rarely successful. However, if it is successful, you would go to a forensic mental health hospital like Mid-Hudson. And then pretrial detainees in local correctional facilities, so those are jails who need inpatient care. So you get arrested and then you're decompensating, go to CL 508. And then if you decompensate once you're already sentenced, then it's CL 402. And then you would also go to a forensic mental health facility like Central New York State Psychiatric Institute, or MARCI, which is in upstate New York. So what we typically see when we talk about offenders with mental illness is we're usually talking about those with persistent mental illness or severe and persistent mental illness, like schizophrenia, those people who have positive symptoms, meaning they experience hallucinations and delusions, those who have negative symptoms where they just kind of withdraw and it looks a lot like depression. Oftentimes they can be almost catatonic. They're not taking care of their hygiene. They many times don't speak. There are other psychotic disorders that people can be suffering from, like schizoaffective disorder, where they have both psychotic symptoms and symptoms of mood disorders like depression. People can have delusional disorders. I once interviewed a man who was convinced that the FBI had implanted electrodes in his penis, which were directing his behavior. But if you didn't ask him about that, you would not know there was anything wrong with him. We also see what was traditionally called manic depression, is now known as bipolar disorder, where people have periods of mania and depression. So sometimes in those manic periods, people can become psychotic and engage in criminal behavior and get arrested. We also see people with extreme depression and substance use disorders. So about 1/8 of state prisoners are receiving some part of mental health or counseling services, and about 10% of inmates get psychotropic medications, meaning medications such as antidepressants, stimulants, sedatives, tranquilizers, or other antipsychotic drugs. And about 10% of those who are identified as mentally ill are receiving 24-hour psychiatric care in special housing or psychiatric units. So these are significant numbers of individuals who are getting psychiatric services within the criminal justice system. So when we treat individuals with mental illness, we either do that within the prison mental health services. So sometimes a prison, for example, Rikers Island, will have a psychiatric ward where people who have mental illness will go. This can be short or long term. There are also forensic mental health hospitals, that's like Mid-Hudson Psychiatric Center or Central New York State Psychiatric Hospital, and those are forensic mental health hospitals. So they are maintained by the Department of Corrections, but they have staff from the Office of Mental Health who work in there. And in general now, there's a huge push to do better screening at the onset. So once people are sent to prison or to jail, even before they're sentenced, and after they're sentenced, we're trying to do much more rigorous intake policies to determine who has a mental illness, because we don't always know, or people don't always tell us, who may be suicidal, so that we can provide them with adequate treatment and put them in the proper placement. For example, if somebody is suicidal, we want to put them, on supervision so that they won't do anything to hurt themselves. So treatment with those with mental illness often involves medication, so that's where the psychiatrists are involved. We also provide specific focused treatment, not necessarily regarding criminogenic needs, but on coping with mental health services in groups and individual counseling, which are done by psychologists, social workers, and psychiatric nursing. This is both for psychiatric problems, which is probably the majority of the individual counseling, and also for criminogenic needs, which you may see with groups, and which can pertain to substance abuse, or you'll see dual diagnosis groups for those who have persistent mental illness and substance abuse. We also have lawyers who are trying to get clients the best services they can, meaning that the clients may be mentally ill, but it wasn't detected by the criminal justice system. So then the lawyers are trying to get them the adequate status so that they can get the mental health services they need. We have assessments that are being done to determine people's risk and their treatment goals, which are generally done by psychologists. We have people who are liaising with the community. So once people are ready to be released, the social workers are working with families in different agencies. There's programs such as Pathways, which are working with people with mental illness to help them reintegrate by providing housing and support services. And then we see things like supervision and parole, where we have special parole and probation officers who are trained to work with those with persistent mental illness. There are also mental health diversion courts. So sometimes if it's identified early on that people are mentally ill and that has resulted in them engaging in the crime and they're not going to get an NGRI, then they may get sent to mental health court, where the judge has special training on working with individuals with mental illness, and they are then referred to services instead of being sent to the criminal justice system. We're also working with police officers to try to help them identify those with mental illness, so that they're directing them to psychiatric facilities instead of prisons when at all possible. So there's been a hallmark ruling in 2011 in California by the U.S. Supreme Court, which was Brown versus Plata, where they ordered the release of over 40,000 prisoners because there were inadequate mental services, primarily mental health care in the state, which was a violation of the minimal care requirements under the Eighth Amendment. Because they did not have enough beds to treat individuals with mental illness, people who were suicidal were being held for long periods of time in telephone booth-sized cages that did not have toilets. One psychiatric expert who testified said that he saw an inmate who'd been held in that kind of a cage for 24 hours and was standing in a pool of his own urine and was unresponsive and nearly catatonic. So you can see these are very horrible conditions. The prisons justify that was, what they could do, because they had no other place to put a suicidal inmate, which obviously is a gross violation of people's human rights. One of the other things that we're talking about when we talk about mental illness, more broadly defined, is individuals with intellectual disabilities. So in DSM-5, which is the Diagnostic Statistical Manual for Mental Disorders, which is in its now 5th version, these fall under neurodevelopmental disorders. So you have intellectual disabilities, communication disorders, autism spectrum disorders, ADHD, learning disorders, motor disorders, and other neurodevelopmental disorders. So generally when we're talking about offenders with intellectual impairments, they have to have significant cognitive delays, meaning more than 2 standard deviations below the mean. So in our traditional IQ test, the mean is 100 with a standard deviation of 15. So it means that they would generally have an IQ below 70. They would have significant problems with adaptive functioning, meaning they could not care for themselves without help. They cannot do their basic activities of daily living, such as, hygiene, working, providing for themselves. And the onset has to be during the developmental period, so during childhood. So if an adult has a brain trauma that causes, cognitive impairments, this wouldn't be an intellectual impairment under the DSM. So it's suggested that between 4 to 10% of the prison population has an intellectual disorder. We are not very good at detecting this. So because people don't obviously, it's not necessarily detected as somebody goes through the criminal justice system. If it is, they can be referred to the Office of for those who have intellectual disabilities, and they can be routed away from the criminal justice system and held in kind of residential programs that are secure. And in the last decade, the U.S. Supreme Court issued a landmark ruling prohibiting the execution of those with mental retardation at the time, which is now called intellectual disability. However, again, there are problems with the definition because they didn't specify how an intellectual disability was defined. Generally, people use the IQ of 70, but if they have good functioning, they don't necessarily meet the criteria. So it's not been clear, and there was a controversial case with somebody who technically was said to be intellectually disabled, was executed in Texas. That was about 7 or 8 years ago now. In terms of treatment of offenders with intellectual impairments, the residential programs that we see are primarily focused on those who've committed sexual offenses. Because of their cognitive impairments, they often don't properly assess right and wrong. They also do have sexual needs as they become adults. They still have the desire to engage in sexual behavior. However, they don't know what's appropriate and what's not appropriate. And so they'll commit sexual offenses. That doesn't mean they're not dangerous. They could still reoffend because they don't understand. So what people have tried to do is use behavioral treatments using token economies, adult education, behaviorally based interventions, sexual education, very broadly defined because many individuals who have intellectual impairments don't receive basic sex ed, and then working with the community to reintegrate them in terms of keeping them employed and working with and supervised. One study looked at the effect of such programs on sex offenders who have intellectual disabilities. They had mild IDs, meaning that they were just slightly below 70 in terms of their IQ, and they were also able to function at reasonable levels while still not maintaining the basic ability to maintain, their ADLs. And so 6 of the subjects were referred for treatment for paraphilias like rape, attempted rape, pedophilia, and frauderism. So 3 of the subjects refrained from engaging in subsequent behaviors. 2 were determined to have made substantial progress, and 2 didn't achieve program targets. So this was deemed to be a success, and they indicated that such types of interventions would be successful in working with people with intellectual impairments. But if you are doing or developing treatments with those with learning disabilities, you want to have things that are focused on behavioral interventions, hands-on activities. You want to have a reinforcement schedule so that they're getting reinforced periodically for on-task behaviors. Things should be done very concretely because those with IQs below 70 have a difficult time understanding abstract reasoning. You need to do a lot of practice and in-session rehearsal, and then you have to supervise them once they're in the community. Individuals with intellectual disabilities are generally high needs and high risk. Therefore, the programming needs to be intensive and long-term. So kind of shifting gears a little bit. So even if somebody doesn't have a persistent mental illness, at the time of their incarceration, they can become mentally ill due to the stressors of the prison environment, being separated from their family, the violence that surrounds them, being sexually assaulted, just being in the criminalized environment, and the isolation. There's been a lot of debate about solitary confinement in prisons. California was expanding their supermaxes, which are where people are held in isolation, individual cells for 23 out of 24 hours a day. They get 1 hour of outside time, which is an individual pen. Pelican Bay is one of such facilities. If you have a chance, I would Google that, and they have videos kind of showing you what that's like. They don't even their food, they don't see a human being. It kind of comes to them on trays in their office. They're also secure housing units. So these are special facilities that are designed to house people in segregation. These are usually done for the management and security of inmates of those who are violent or disruptive while incarcerated, but it can also be for vulnerable populations like sex offenders who, might be, or people who are suicidal, who might be targeted or who, can't be with the general prison population. And so what you see, there was a researcher at Harvard who did a lot of study of those in segregation. And you're deprived, you have sensory deprivation, and there's very little stimulation in the environment. And so you're alone in your cell nearly all day. It doesn't stimulate any of your human senses like sight, touch, taste, smell, and sound. And depending on the type of individual, people don't tolerate it very well, and also the degree of time that you are in a situation. I remember watching a episode of Special Victims Unit when Stabler went into a segregation for a weekend, and he thought he'd been in there for, I think, like months, and it had only really been 2 days, and it really affected him tremendously. Now imagine somebody who's already mentally ill, who has hallucinations and delusions, is now in segregation because their behavior becomes more erratic because of the mental illness, and these are just exacerbated with these symptoms. So people report hearing voices, having panic attacks, difficulty in concentration and memory after being released. They're disoriented, their mind wanders, they have aggressive fantasies, they become paranoid, they begin to doubt what is real and not real. You see signs of random violence, they become depressed, and you also see people engaging in self-mutilation. That could be because they're trying to get out of there, and so if they cut up, they get taken to a mental health facility. One other issue that's kind of salient for those in the criminal justice system is head injury. And there's a lot of statistics showing that those who are involved in the criminal justice system are significantly more likely than those in the general population to have a traumatic brain injury, or TBI, generally resulting from childhood abuse, accidents, violence-related injuries, being involved in prison violence, and also self-harming. Like I saw one client who had tried to make a suicide attempt by hanging, and he'd been unsuccessful, but he deprived himself of oxygen for a sufficient amount of time that he now had a traumatic brain injury. So as a consequence of a TBI, you see decreased attention span, brain damage, paralysis, or motor impairment. So these can impact individuals' ability to reintegrate into the community, can impact the way they function in the prison system, and also respond to treatment. So you want to have neuropsych exams to see where those deficits are, MRIs, and then you need to develop individualized treatment plans addressing the deficits that result from the TBIs. And the last topic we're going to talk about today is suicide and self-mutilation, which we're seeing in high numbers in the criminal justice system. Suicide in prisons is anywhere between 1.5 and 2 times higher than that of the general population. We're seeing a lot of that happening in jails because there's not as much ability to assess and keep people secure. The environments are also not as secure as they are in prison. So people hang themselves on, the YouTube of a sink. They use their clothing to hang themselves, though they can more easily get access to tools to hurt themselves. And suicide rates in detention facilities, so that's jails, is reported to be 9 times higher than that in the community. Self-mutilation, as you can see in the picture on the right, is when people kind of cut themselves. You'll see a lot of people who scratch or cut their skin, but it can also be more severe. We've seen things such as eye enucleation, which is they're taking out their eye, people, stuffing things and cutting themselves, and like they're in their stomach and stuffing things in there, breaking their bones, amputating limbs, pulling out their own hair. These can be side effects of mental illness, or they can be, there are many different purposes. Sometimes it's escape and avoidance, because if you self-harm, they take you to the mental health hospital in many cases, which is much less restrictive in the prison environment. Or if you're in segregation or in a dangerous situation, you may want to get out of there, and that's one way to do it. Maybe because you're experiencing depression, that you're having a hard time dealing with that. People who have PTSD and psychosis can often self-harm. We see mood regulation, so those with borderline personality disorder sometimes will cut to help them kind of feel more present. And then some people just do it to manipulate their environment, like they need a break, as I mentioned earlier. So it's important when treating somebody who's engaging in self-harm behaviors to understand why they did it, because the treatment for somebody who's trying to manipulate the environment is very different than somebody that's experiencing psychotic, hallucinations of somebody telling him to cut himself or pull out his eye. So some of the risk factors for suicide include a past history of suicide attempt, active discussion of suicide plans, changes in sleeping, eating, or other personal habits, so they stop washing, bathing, things like that. A recent personal crisis, or finding like their wife or their children leave them, or they may just find out they've been sentenced to life in prison. And you'll also see a loss of interest in relationships that they had previously engaged in. So how do we treat this? We have medication that can be prescribed. It's not a solution in many cases, but it's at least a panacea. We also have isolation, where you take somebody out of the criminal justice, out of the general prison environment, and you have them on one-to-one watch, but then you encounter the same issues as you would with somebody that is in segregation. You have individual counseling, and where you're teaching people problem-solving strategies, so how they can deal with these feelings, emotions, issues that they have without hurting themselves.